Welcome to this lecture where we will be looking at chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, otherwise known as COPD, is a chronic and progressive disease that limits airflow through the lungs and is irreversible. COPD is an umbrella term that incorporates two conditions, chronic bronchitis and emphysema. And the reason that these conditions are termed COPD is because often they overlap, with one being more prevalent in a patient's condition than the other. Before we look at the pathogenesis of COPD, let's go over some basic anatomy and physiology. Alveoli are the functional aspects of lung tissue that are responsible for the gaseous exchange of oxygen and carbon dioxide. In order for air to be exchanged between the atmosphere and the alveoli, it must first travel through a network of tubes within the lungs known as the large and small airways, which consist of the main bronchi, bronchioles, and tertiary bronchioles. These airways do not participate in the diffusion of gases, but provide the alveoli with access to the external environment. There are several defence mechanisms that protect the alveoli from pathogens to ensure they remain sterile. The trachea and bronchi contain pseudostratified columnar epithelial cells, which have cilia on their apical surface which beat mucus away from the lower respiratory tract. Amongst these cells are goblet cells, and they're responsible for secreting the mucus. This defence mechanism is known as the mucociliary escalator, and works by trapping pathogens within the mucus, which is then moved up by the cilia in a brushing motion, allowing the mucus to be coughed up or swallowed. Immunoglobulin A antibodies are presented on the surface membrane of cells within the respiratory tract. Immunoglobulin A antibodies work by binding pathogens and neutralizing them to prevent them from causing infection. Within the alveoli, there are fixed macrophages, known as alveolar macrophages, and they provide a way of eliminating debris and foreign matter through phagocytosis, as well as being able to excrete cytokines that recruit other immune cells to the area, such as neutrophils and lymphocytes. Let's start by looking at the pathogenesis of chronic bronchitis. Chronic bronchitis is diagnosed when a patient has had a productive cough that continues for 3 months of the year for at least 2 consecutive years. The constant exposure the airways have to irritants, such as tobacco, causes damage from constant inflammation and recruitment of immune cells. This inflammatory process leads to bronchial edema, hypertrophy of bronchial smooth muscle, fibrosis of the airways, and hyperplasia of mucus glands and goblet cells, leading to excess secretion of mucus in an attempt to protect the airways from the pathogens. The constant exposure to irritants and the hypersecretion of mucus causes ciliary dysfunction. The cilia become destroyed and less motile, meaning they struggle to remove the mucus and pathogens from the airways, leading to mucus plug formation and airflow obstruction. The failure to clear pathogens due to the impaired pulmonary defence mechanisms leads to further infection and inflammation, worsening the condition. The thick mucus leads to narrowing of the airways and mucus plug formation. Because inspiration is an active process that uses muscles of respiration, this partial airway obstruction can be overcome, although the amount of air inspired can be reduced. The difficulty occurs during expiration, as this is a passive process where the respiratory muscles relax. The pressure of expired air struggles to overcome the narrow airways, leading to air becoming trapped in the alveoli. In particular, the elimination of CO2 is reduced. We know that oxygen and carbon dioxide will move down their concentration gradients from areas of high quantities to areas of low quantities. Usually, carbon dioxide in the alveoli is of a low partial pressure, meaning that it is in a lower quantity than in the blood. This enables CO2 to readily diffuse from the blood into the alveoli, where it is exhaled, as it is moving from an area of high pressure in the blood to an area of low pressure in the alveoli. Oxygen is of a high partial pressure in the alveoli, meaning there is more of it in the alveoli than in the blood. This causes it to readily diffuse across from the alveoli into the blood, moving from an area of high concentration to an area of low concentration. This process of carbon dioxide leaving the blood and entering the alveoli, and oxygen leaving the alveoli and entering the blood, is named the Haldane effect. In chronic bronchitis, the amount of carbon dioxide within the alveoli is increased as it becomes trapped, meaning it's more difficult for carbon dioxide to leave the blood and enter the alveoli. This is because the difference in partial pressures of carbon dioxide between the alveoli and the blood is reduced. Likewise, the amount of oxygen within the alveoli is reduced, making it more difficult for oxygen to move into the blood, as the difference between alveoli oxygen levels and blood oxygen levels is narrower. This leads to reduced oxygen levels within the blood, known as hypoxemia, as well as increased carbon dioxide levels in the blood, known as hypercapnia. Now let's look at the pathogenesis of emphysema. Emphysema is characterized by structural changes to the alveoli and small airways. The alveoli are the functional aspects of the lung responsible for gaseous exchange. The small airways are responsible for the passage of air between the atmosphere and the alveoli. These changes are caused by a breakdown in elastin. Elastin is a protein of the extracellular matrix. It is highly elastic and is present in connective tissue. This allows the alveoli to resume their shape after stretching or contracting. The loss of elastin causes the alveoli to collapse during expiration. This is because high velocity airflow through the airways causes the pressure to rapidly decrease. The loss of elastin keeping those alveoli open during expiration causes air to become trapped in the alveoli. This air trapping leads to the same manifestations as air trapping in chronic bronchitis, with increased carbon dioxide levels in the blood and reduced oxygen levels. The elastin is broken down by the chronic inflammatory process taking place within the alveoli. Alveoli macrophages will phagocytose the toxins or pollutants which enter the lung. These macrophages release particular cytokines when they have encountered a pathogen. These cytokines cause cells to move to the area to help eliminate the pathogen. The main cell recruited to the area are neutrophils, and they secrete proteases, A's to mean breaking down. The main protease released is elastase, which breaks down the elastin within connective tissue, but there are also some collagenases released which will break down the collagen in the extracellular matrix. As elastin is broken down, not only do alveoli lose their ability to stretch and recoil, but the elastase destroys the septa within the alveoli. This loss of tissue greatly diminishes the surface area available within the alveoli for diffusion to take place. Destruction of alveoli can lead to large air spaces within the lung tissue being formed, known as bullae, and pleural blebs, which are air sacs adjacent to the pleura. This greatly increases a patient's risk of suffering from a pneumothorax. Emphysema can be further broken down into which part of the lung is affected, but this is of little clinical use as it won't change the management of these patients, and quite often investigations are not conducted to identify where the emphysema is located. Centri acina emphysema refers to destruction of the proximal airways and alveoli. Centri meaning centre and acina refers to a region of the lung tissue. Paraseptal emphysema refers to emphysema that occurs next to the pleura and can cause blebs to form, increasing the risk of a pneumothorax. Panacina refers to random distributions throughout the lungs, but typically involves the lower lobes. As we discussed earlier, chronic obstructive pulmonary disease is irreversible. However, patients can experience exacerbations. An exacerbation is an acute worsening of a patient's symptoms and is most likely going to be the reason that these patients seek medical help, especially in the emergency setting. Exacerbations are typically caused by bacterial or viral infections, which acutely worsen the underlying disease associated with COPD. Other triggers include exertion, stress, and non-compliance with medication. Be sure to check out our video on the signs and symptoms of an acute exacerbation, as well as the emergency management. Now let's look at the causes of chronic obstructive pulmonary disease. The main cause of COPD is smoking, which is responsible for approximately 95% of cases. The toxins in smoke cause chronic immune responses, which cause irreversible damage. Another cause is air pollutants, or patients who have been exposed to pollutants and strong chemicals through employment. A much rarer cause is a genetic condition called alpha-1 antitrypsin deficiency, which is an autosomal dominant disease. This will typically affect people before the age of 40, and there will be a family history of the disease. Alpha-1 antitrypsin is a protease inhibitor synthesized by the liver and helps to regulate the activity of proteases. As we discussed, a protease breaks down proteins, and alpha-1 antitrypsin inhibits proteases. A deficiency in this protease inhibitor leads to an excess of protease activity, which predominantly affects the lungs, causing emphysema, and the liver, causing liver cirrhosis. To recap, chronic obstructive pulmonary disease is a progressive disease that limits airflow through the lungs and is irreversible. It is primarily a problem with expiration and not inhalation. COPD is primarily caused by smoking, but can also be caused by exposure to pollutants, as well as the genetic condition alpha-1 antitrypsin deficiency. COPD is the umbrella term that incorporates two conditions, chronic bronchitis and emphysema, and the reason these conditions are termed COPD is because often they coexist. Normally a patient will have one disease that is more dominant than the other. Chronic bronchitis is the hypersecretion of mucus due to chronic inflammation, which will cause a patient symptoms, whereas emphysema causes structural changes in the alveoli and small airways. An exacerbation is an acute worsening of a patient's symptoms and is most likely going to be the reason that these patients seek medical help. It is essential that these patients are appropriately assessed and managed. Thank you for watching, and I hope you found this video helpful. Be sure to check out our other video on the signs, symptoms, investigations and management of COPD. And if there are any topics you would like us to cover, then please leave a comment in the comment section below.